Good morning, everyone. Today my topic is truncus arteriosus. It's a journal club plus class also. So overview, it contains definition, pathophysiology, clinical features, diagnosis, management, and then contemporary practice, our experience, and then discussion. So truncus arteriosus, coming to the definition, it's a congenital cardiac malformation where a single arterial trunk arises from the base of the heart over its interventricular septum and supplies systemic, pulmonary, and coronary circulations. All should meet the definition. And anatomic characteristics: no separate pulmonary valve or ventricular to pulmonary artery continuity. This actually distinguishes from the severe forms of tetralogy of Fallot with the pulmonary atresia, where the remnants of pulmonary valve and the trunk will be persisting. And then epidemiology, relatively, it's uncommon.
Don't say Fallot.
Fallow.
Yeah.
Incidence is 3 to 10 per 1 lakh live births, accounts to approximately 4% of all critical congenital heart anomalies, and accounts to 0.21 to 0.34% of congenital cardiac cases. Coming to embryology, normally truncus arteriosus divides and spirals into aorta that goes to the posterior, and pulmonary artery comes to anterior. In persistent truncus, this division fails, persisting, representing arrest in the development of the at the conotruncal stage. So contributing embryologic abnormalities are absence of spiral septation of the truncus, small rotation and abnormal ventricular routing, subinfundibular atresia, malposition of semilunar valve analgesis, and neural crest cell disruption, which they have seen in chick embryo models and leads to conotruncal defects. Also explains association with Reger's syndrome, that is 22q11.2 deletion, due to the shared pharyngeal arch origins, thymus and parathyroids. So here comes the syndromic association. Nearly 30 to 40% of the cases will be associated with Reger's syndrome. High incidence in truncus arteriosus, which is seen. Associated findings include complex cardiovascular anatomy and depressed immune status and due to absent thymus, and then pulmonary vascular reactivity is high. Neonatal hypocalcemia will be there, bronchomalacia, laryngeal web, and tendency for airway bleeding. All this to be kept in mind while evaluating a case pre-op, and things to be anticipated in the post-op in the ICU. And in drop, we have to note the findings of the thymus, whether it is present or absent. And anatomic features. Great artery is single arterial trunk, everyone know, but it's mostly from the right side, that is 42% towards the right side, and towards the left side it is 16%, and equally being shared is in 42%. So either it should be in between or towards the right mostly. And coming to the classification is depends on the pulmonary artery anatomy. So Collett and Edwards, which is the first classification, which divides into type 1, 2, 3, 4. In type 1, main PA arises from the truncus and then bifurcates. And then type 2, separate but closely spaced PAs arise from posterior truncus. It's posteriorly arises, but they are closely spaced. And in third one is widely separated from PAs, mostly from the lateral side. And fourth one is the only one PA, both the PAs arises from the descending thoracic aorta, but now it is being considered as VST plus pulmonary atresia plus MAPCUS, not true truncus form. And then this is being modified with Vanpara classification, A1, A2, A3, A4. Here A1 is equal to Collett and Edwards type 1, no change. And A2, A3, coming to A2, merges type 2 and type 3. That means there is no difference between the posteriorly placed, closely placed pulmonary arteries or from the laterally placed pulmonary arteries. All these actually have same surgical procedures. So being merged as A2, and type A3 uh, tells that only one pulmonary artery from the trunk, usually from the RP, and the contralateral lung is from the ductus or from the collaterals. These cases also will be seen quite frequently, around three cases in 100, and then A type A4 truncus arteriosus with interrupted aortic arch. In these cases, around in 100, we can see around 5 cases. Recent modifications focus on aortic versus pulmonary dominance. So, depending upon the truncal artery, which is forming actually aortic or pulmonary dominance, focus down in that way, because management principles differ in both the things. And Jacob's hierarchical system, it's a computerized nomenclature to include all known variants for global registry, outcomes tracking, and risk stratification. So anatomic variants of and associated findings is a right arch is seen around 30%, PDA also seen in some cases, and interrupted aortic arch is about 11 to 14%, typically in A4 substrate. These are the two diagrams which show aortic versus pulmonary dominance. In aortic pulmonary dominance, we can see ductus is continuing as a descending thoracic aorta with the interruption of aortic arch. And in aortic dominance, it is continuing as this thing, and branch pulmonary arteries being arrested from the lateral posterior surface of the aorta. These are the cine cardiac angiograms which show type 1 truncus from the IP view and the lateral view in both these things, and then this is interrupted aortic arch being seen in cine cardiac view. Coming to the morphology of the VST. VST typically large non-restrictive located in the anterosuperior septum, lies between the two limbs of the trabecular septa marginalis. These are the two limbs of the trabecular septal marginalis which lies above it. So the superior surface is being marked by the truncal valve. Sometimes extends towards the membranous septum, that is very rarely. Risking while doing the closure, we may cause a heart block only in such type of VSTs. Otherwise, in a straightforward truncal VST, it is very rare to cause a surgical heart block. Coming to the truncal valve. Truncal valve usually, if it has a problem, it will be insufficient, that is regurgitation, and rarely stenotic. So mostly tricuspid 60%, but quite a few number of cases will have a quadricuspid around 25%. Rarely bicuspid, that is 5%. Coronary artery anomalies usually seen like single coronary artery origins and high ostial origins with intramural courses above the sinus of Valsalva. Physiology, primary pathophysiology feature is it's a large left to right shunt through VST and common arterial trunk. Progression, pulmonary blood flow increases after birth as the pulmonary vascular resistance drops, and then truncal valve regurgitation occurs in about 50% cases. So there is already pressure overload, and then volume overload also starts, and then pulmonary vascular obstructive disease can develop by 6 months, making early surgery essential. Clinical features, onset within the first few weeks of life. Usually, some patients will have sinuses from the birth, and key signs are congestive heart failure patients. Usually, they manifest with congestive heart failure rather than cyanosis. So, tachypnea, costocernal reflection, septomegaly, failure to thrive, and sweating with fits. Murmurs from VST pansystolic murmur, and if truncal regurgitation is present, it's a diastolic murmur. Cyanosis is variable depending upon the balance between systemic and pulmonary circulations, and if there is a truncal regurgitation, bounding pulses, and single heart sound, because there is no P2, single H2. ECG normally sinus rhythm by ventricular hypertrophy. LV forces if there is high pulmonary blood flow because of volume overload, and RV forces with the pulmonary vascular obstructive disease, which develops usually after the six months. So chest X-ray is cardiomegaly, increased pulmonary markings, right aortic arch, which is seen around 30% of cases, absence of normal pulmonary artery segment, unilateral vascularity, that means the other side PA is atretic, and bilateral decreased markings means advanced pulmonary vascular obstructive disease, which is seen in later of the life. Imagings are helpful for a diagnosis, which we can see and diagnose through echocardiogram. Most of the things, only cases which have interrupted aortic arch or which we have doubt regarding the coronary status, we can go with CT angiograph, CT cardiac pediatric, to see the pulmonary arteries and coronaries. Cardiac catheterization is done only in late presentations most of the times, and to confirm the diagnosis if other modalities are inconfirmatory. Natural history coming to 65% die by 6 months and 75% by 1 year. The survivors may develop pulmonary vascular disease that balances flow for some time, and then later they will also succumb to death. Early surgical repair within the first 2-3 weeks improves prognosis. Medical management, usually it's supportive till the patient comes to the OT table. That's only this failure medication, that is diuretics, digoxin, and vasodilators. And coming to Dyeser syndrome, you have to keep in mind the calcium and magnesium levels, which need to be supplemented. And if blood products has to be given perioperatively, usually it should be irradiated blood. And because the thymus absent deficiency, immune deficiency, treatment and prophylaxis against pneumococcal and streptococcal infections is important. And immunization with live vaccine should be avoided. Usually patients with syndromic truncus, means truncus babies who are syndromic, usually won't get tested before the operation. Usually in our hospital, being referred to genetics post surgery. That means only the clinical features will tell us whether this patient is syndromic or not. Otherwise, documentation will happen only after the surgery. Historical surgical approaches. Coming to historical surgical approaches, usually started with PA banding. As usual, for all increased pulmonary blood flow, started with PA banding. Results in high mortality and ineffective outcomes. And then initial complete repairs performed usually in older children due to technical limitations and size concerns. And then slowly, it led to delayed interventions, often causing death before repair. And then Megons, inspired by Rastrelli, introduced a complete repair using a valved conduit between RV to PA. So Rastrelli concept is to restore RV to PA conduit via valved conduit reconstruction. And then Abbott et al. Came, demonstrated safe and effective repair in infants less than 6 months, and then started the early primary repair. So coming to the technique of repair, separation of aortic and pulmonary trunk is the first step, and then VSD is closed in such a way that the LV ejects into the truncus upwards, and then establishing the RV to PA continuity, and then repairing the regurgitant truncal valve if it is. After going on setting up the cardiopulmonary bypass and cross clamping, we can see here antegrade cardioplegia is given, cardioplegia cannula is there, and then MPA is being looped and snared with selective bicaval and aortic cannulations. So first detaching the pulmonary arteries, here we have to see it is different in types. That is type 1, only a limited incision made on the anterior aspect of the main pulmonary trunk like that. And then from there we have to see the truncal valve, ostium of the left coronary artery, and then pulmonary arterial orifices we have to see. And then incision is carried inferiorly and posteriorly so as to detach the pulmonary artery completely. And then defecting the aorta is usually closed transversely by direct suture, and sometimes if it is large, we have to use a patch. Sometimes it can be polished Dacron patch or Gore-Tex patch. Mostly in our institute, we use a pericardial patch. Truncal repair can be accomplished without addition of the pulmonary bifurcation directly by putting a patch like in AP window also. In type 2 and type 3 truncuses, transect completely the aorta distal of the truncus because these are posteriorly or laterally placed. With a cuff, we have to take it out and then we have to repair the aorta later. Distal aorta is open transversely on its anterior surface and incision continued posteriorly above the orifices of the pulmonary arteries, which are detached as an elliptical button containing both orifices. We can see this is the curve. So the ascending aorta, which has been fully mobilized, is reconstructed by end-to-end anastomosis after this. So wider bites being taken on the proximal segment, because the proximal segment is larger than the distal segment after the origin of the pulmonary truncus. Closure of the ventricular septal defect. An oblique right ventriculotomy incision is made at about the midpoint of anterior right ventricular wall to base near left aspect of annulus on free margin of the defect. The defect is closed with patch with continuous sutures usually, and anteriorly and superiorly sutures are placed to the anterior wall of the right ventricle as horizontal matrix sutures, which can be reinforced. Sutures are placed on free margin of defect if it is muscular defect, away from the posterior margin if it is in the perimembranous defect, usually principles of VSD closure. Establishing RV to PA conduit, usually allograft, that is homograft aortic or pulmonary valve conduit, autologous tissue for right ventricular to outflow, right ventricular outflow tract. So either we have to use conduit or we can use autologous tissue. So coming to conduit, if you are using allograft to prevent crinking homograft distension, it is trimmed 2 to 3 mm distal to the commissural attachments of the pulmonary valve to provide an adequate anastomosis and size match to the pulmonary bifurcation using a large pulmonary homograft of 12 to 18 mm in diameter. An incision is carried into the origin of the right RPA for a short distance and more significantly into the LPA if additional opening is necessary. Here we can see this is how we have to match the sizes of the conduit with the pulmonary artery conduit, pulmonary arteries cuff. So we have to extend into the RPA side and then if needed more into the LPA side also, make the size discrepancy to match the size of the conduit. And then allograft conduit anastomosis distal to pulmonary trunk. Posterior half of the proximal anastomosis is made like this. And then anteriorly, the hood is made with a prosthetic patch or a pericardium material. So coming to autologous tissue being used for repair of truncus is more or like a tap, that means transannular patch kind of thing. That is the posterior wall has to be made with the autologous tissue, and anteriorly we have to cover up with the pericardium. So separation of PA and then aorta is the same, and then the lower half of the this thing will be stitched to the upper end of the ventriculotomy. So like this, and the inferior aspect of the original truncal incision is attached up to the upper portion of the right ventriculotomy using fine polypropylene suture, and the roof is placed on opening with essentially the same technique and materials used for inserting a transannular patch. So it more looks like a transannular patch without any truncal pulmonary valve in it. So then Barbaro Marshall came and then he modified the technique. He made it a modified Barbaro Marshall technique, and then he used opening of the pulmonary arteries if far away from the ventricular artery, so that it is of a posterior wall of the right ventricular appendage, which is next to it. Either it is without opening, we can use opening. If we are opening the later then water soon and flap and area to bridge the gap. If as an in of the left atrial appendage to interpose in between the both. But here the problem is that after cardiac distension and contraction of the atrium, the bridge may compress the left coronary artery, which may cause myocardial ischemia. So the thing has to be seen. Truncal valve repair. Coming to truncal valve, most of the valves which are regurgitant are quadricuspid valves, so which has a rudimentary fourth cusp, which we have to remove and make it tricuspidization. So tricuspidization is the standard technique of repairing the truncal valve, where there are so many combinations and permutations and combinations regarding where the place of the rudimentary tricuspid valve and in relation to the coronary arteries. If the coronary button is coming in the way, then we have to harvest it, get it outside, repair the this downsize the annulus, and then reattach the coronary button like bender. And then other aortic valve repair principles like annular downsizing and then commissural plication, all these things also can be used for repairing truncal valve. Now, knowing what are all the things which are available, coming to the surgery for truncus arteriosus, a contemporary practice. This is actually an Australian made article, but it's an review article which they have reviewed all the data which is there in the internet and then made an article of the contemporary practice, what the world actually around practicing around us. Published in 2021 in the Annals of Thoracic Surgery. So its background is this was first reported by Wilson in 1798, and anatomical details by Buchanan in 6 months old infant. Outcomes and mortality, despite advances and operative mortality in the last decade, remains 3 to 20%. So high-risk anatomical variants, according to the study, is a truncal valve with the truncal valve, tricuspid atresia with the truncal valve insufficiency, concomitant interrupted aortic arch, anomalous coronary artery anatomy. Surgical challenges, optimal RV2 PA conduit reconstruction method remains undefined, and then goal is to minimize reoperation rates and improve long-term outcomes. Purpose of review is to analyze current outcomes of truncus arteriosus repair, focus on evolving surgical and perioperative strategies to reduce mortality and reintervention. So methods is database searches, and then with appropriate search terms. Inclusion criteria is in the last 20 years. And frequently cited older studies also included. After reviewing all the articles, they came to the outcomes is early mortality is 3 to 20%, depending on perioperative factors and associated anomalies. So, and then long-term survival is 75% at 20 years and improved to 92.5% if the patient survives the first post-operative period. That means that first post-operative period is crucial, where the patients have higher mortality. So timing of deaths, majority occur within the first year post-repair. So one study showed 57% late deaths within the first year, and then one more study showing 88% of late deaths within the first year. If we pass the first year, then the percentage of survival is around 92%. So timing of the surgery, standard practice is complete repair within the first few weeks of life, around 6 weeks of life, and high risk neonates may require emergency surgery also, who usually have tricuspid valve insufficiency or other anomalies. Reoperation rates is freedom from RVOT reoperation is 3%, and at 20 years, that means 97% will have a reoperation, and then median time to reoperation is around 4 years. 62% will require more than one RVOT reoperation within the 20 years time period. And long-term function is most patients will be in NYHA class 1 or 2, and truncal valve insufficiency, generally mild illness. These are all the studies which they have seen. Usually, the older studies have higher early mortality. Coming to the later studies, survival actually increased. Truncal valve surgery in truncus arteriosus. Coming to truncal valve surgery, truncal valve insufficiency is a critical determinant in the outcomes of truncus arteriosus repair. Mild insufficiency usually tolerated, no one will touch it, but moderate to severe regurgitation influences mortality and reoperation rates. Neonatal considerations, neonates with significant tricuspid valve insufficiency truncal valve insufficiency often present in heart failure. So these cases usually go for an early surgery because it's an emergency surgery. It will become 27 to 40% early mortality reported in neonatal cases. And surgical decision making. So moderate truncal valve insufficiency remains always controversial whether to touch or not, but some centers usually repair moderate plus regurgitation, other opt for surveillance unless a severe symptoms, because anyway patient will come for reoperation for conduit. Surgical techniques, usually what they are following outside is leaflet resuspension, commissural reconstruction, and then tricuspidization of the quadricuspid valve and pericardial patch extension, annular reduction. All these surgical techniques are being used for a truncal valve repair. Outcomes comes to outcomes. Freedom from truncal valve reoperation is 19% at 20 years and 50% and 7 years in different studies. Early mortality up to 30% in complex repairs. Current consensus, severe tricuspid valve, truncal valve insufficiency, surgical repair essential, and annular reduction is emerging as a key technique for durable results. Quadricuspid truncal valve is the most common morphological truncal valve. That means which is actually regurgitating. That means in patients with truncal valve surgery, 57% have quadricuspid truncal valve. And in patients with moderate to greater, that means 79% quadricuspid. Progression risk, most quadricuspid truncal valves with mild or less insufficiency does not require surgery. Only 16.7% with quadricuspid morphology progress to require surgery. Among these, 5 had only mild or less insufficiency initially. That means even though initially patients have mild or less insufficiency in the quadricuspid truncal valves, about 16% patients can progress into the insufficiency. So tricuspidization, tricuspidization plus annulus reduction is the preferred surgical method. That is a leaflet resection, cuspidation reconstruction, and annular downsizing. These are the different ways which we can do, because these will have different combinations. So in relation to the coronary artery origin, because the coronary artery origin, or it will transfer the transmural behind the commissure also. So sometimes it needs reconstruction of both the aortic root and the valve also. So tricuspidization group has 64% freedom from truncal valve reoperation at 10 years, and non-tricuspidization group at 0% and 6 years. That means all the tricuspid valves had reoperations. So tricuspidization yields better long-term durability even in younger patients. Literature supports favors early tricuspidization if it's a quadricuspid valve, even though it is a mild regurgitant valve. Interrupted aortic arch, which is around 20% with the truncus arteriosus, most common is type B. So earlier studies have shown that it's a risk factor for mortality, but now the interrupted aortic arch outcomes have been in par with the normal cases. So modern era mortality risk from interrupted aortic arch has decreased significantly. So survival at 10 years, that is truncus arteriosus with interrupted aortic arch 83% and truncus arteriosus without interrupted aortic arch 74%. Actually, p-value is not significant. That means both are same. So it's no longer a risk factor for risk factor. And then surgical approach for interrupted aortic arch and truncus arteriosus, same end-to-side aortic arch repair, and if we have to use deep hypothermic circulatory arrest with selective perfusion and anastomosis with or without patch or interposition graft. There is an arch distortion post mobilization. Left pulmonary artery compression is a risk. So freedom from aortic arch reoperation is 68% in 10 years, and 3 patients required reoperation within 30 days of initial repairs. So no patch augmentation requires initial repairs because the suture line will be under tension and it will be small in comparison to the patch augmentation. So patch actually appears protective against future obstructions. Coming to coronary artery abnormalities, reported in about 5 to 20% of truncus arteriosus, but the exact prevalence remains unclear due to diagnostic challenges because usually these won't be diagnosed preoperatively, only intraoperatively this will be diagnosed. Types of anomalies include single coronary artery supplying the entire circulation, or atypical epicardial coronaries crossing the RVOT, or from the LAD, or from the higher power regions, or with intramural courses. And then surgical implications, usually compression and distortion in relation to the repair of the truncus arteriosus with RV to PA conduit usually causes these problems. So there comes the problem with the space management also in the small chest with the conduit, extra cardiac conduit. And then intramural coronary arteries, a rare but concerning anomaly which we have to take care because this can lead to myocardial ischemia, compression, kinking, and ridge obstruction in the coronary arteries. So unroofing has to be done while dealing with intramural coronary artery. Surgical correction involves unroofing the intramural segment and establishing a new unobstructed ostium. And outcomes and mortality risk. The association between coronary anomalies and poorer outcomes is highlighted by the studies. The outcomes are worsened due to the difficulty of managing the coronary artery during surgery, particularly when it crosses high-risk areas such like that RVOT. Complications as such ischemia and myocardial infarction can significantly increase mortality. So it has to be kept in mind while evaluating a case preoperatively about the coronary anatomy to anticipate something in intra-op and in post-op also. Coming to RVOT reconstruction, what they are doing is most common one is the conduit use, but direct anastomosis is rarely used, and then conduit reconstruction advantages provides aids in immediate relief, and then disadvantage is that limited durability and it won't grow, regenerate, or require reoperation. Complications is that it's a prosthetic material which can get infected or thrombosis to foreign material. And direct anastomosis benefit is foreign material we won't be using, and challenges are feasibility only in certain anatomical conditions where the length and lie of the pulmonary artery also takes into consideration before doing direct anastomosis. Conclusion is that the best method which they are which has to be used actually is still controversial. Bioprosthetic conduits in RPOT in the first place were in around 1990, that is availability of materials, patient cells, hemodynamics, and surgeon preference, all this taken into account. So usually people have seen prosthetic materials with bovine pericardial valves and then contact valves also. This is jugular venous, bovine jugular venous conduits. These have predictable performances but and lacks immunogenic properties. And some findings have showed a longer freedom from reoperation also. Comparatively, durability is a similar durability across homografts and bovine jugular vein and porcine valve conduits. And bovine jugular vein conduit developed insufficiency and stenosis earlier than other conduits in other indications. Concerns with Contagra is that a twofold increase in reintervention risk compared to homografts regardless of size, and several studies report higher risk of infection with Contagra conduits. Anyway, we are not using this conduit in the discussion. They only for historical importance, and then homografts in RVOT reconstruction until 5 years. Last 5 years, so these are in use. That is overview of homografts. That is pulmonary or aortic, both that can be used. And then usually the limitations are smaller sizes and availability issues and potential for obstruction over time. Advantages are better hemodynamics and increased longevity. 68% freedom from reoperation at 10 years is being reported. Homografts less than 12 mm size means require early replacement. Conduit sizing is usually if size or space in the chest allows, we have to do oversizing of the homografts so that there will be increased longevity. Excessive oversizing, usually if we do excessive oversizing, it will compress on the other things like coronary artery compression or the distortion of tricuspid or pulmonary valves. And then PTFE conduit in RVVTT construction. Advantages of PTFE conduits is that its availability and ease of construction is very easy, lower cost compared to other conduits, and immunologically inert, comparable outcomes to other conduits. So there are different studies which have showed in comparison between the homografts and PTFE conduits with similar rates of intervention and time of intervention for both conduits, and better survival of PTFE conduits at 5 and 10-year follow-up. So larger the conduit, longer the freedom of reintervention. That's the basic principle for every conduit. And then primary mode of failure is fibrosis and narrowing at the distal anastomosis over time. Failure is less likely due to fibrous tissue formation within the conduit itself. Usually, PTFE conduit won't allow fibrosis inside the conduit. Only at the anastomosis site it will make it. Then direct RV to PA anastomosis avoids the use of non-living conduits. That lack growth potential. So it is usually can be done only in type 1 truncus arteriosus. 89% with the direct and freedom from RVOT reoperation is at 4 years is 89% with direct anastomosis again, and then 58% change due to conduit repair in the second operation. So limitations and challenges requires favorable anatomy and risk of pulmonary artery distortion. If it getting discharged and distorted, and it will lead to early reoperation again. Potential for severe pulmonary regurgitation because there is no valve. But actually there is a modification, one more modification where when we are doing direct anastomosis, we can use a monocusp valve with the treated pericardial patch. And then modifications for better outcomes is patch augmentation of anastomosis suggested, and then which reduces distortion and allows interval growth. So long-term quality of life after truncus arteriosus. Usually, quality of life is similar to Fontan patients. That means usually they will have lower than normal, like lower normal levels of exercise tolerance, minimal oxygen consumption, and maximal work capacity, post-wide capacity. Psychosocial function is not significantly impaired and indicates moderate morbidity and disability. Adult outcomes, quality of life in adults with truncus arteriosus comparable to adult age-matched controls, and quality of life to those with arterial switch operations despite higher reoperation rates. So even though arterial switch operations are single single stage operations, comparable quality of life can be achieved. Only thing that they will have reoperations again and again. Physical functioning domain consistently lower across all age groups. Limitations of current assessment is that physical capacity is not objectively measured and unclear whether reduced function is due to lifestyle or cardiac limitations. Need for quantitative physical assessments has to be done. So the conclusion is excellent long-term survival post-surgical repair and high reoperation rates. So everyone knows it's due to RVOT conduit use and truncal valve. Sorry, it's truncal valve. So truncal valve competence is the key predictor of early outcomes. Mild insufficiency is freedom from surgery up to 25 years, and moderate to severe means freedom which needs lifelong intervention in terms of repairs, re-repairs, and then replacements. So for further understanding of the topic, here I am giving you 3 links. Actually, the first link is that is about the truncal valve repair, that is quadricuspid valve being tricuspidization with the intramural coronary artery, how it is being done, which is being it's a video article. And then second one is our institute, Dr. P.R.T. sir's truncus arteriosus repair with RV2 PA conduit using PTFE tricuspid valved conduit in type 2 truncus arteriosus, which is freely available on YouTube. And then third one is how to prepare that conduit is actually Shrikant sir's and Sudesh Prabhu sir's article, which is also a video article in MMCTS, which is being published. So for further understanding, we can see these 3 videos, which we will get most of the idea. And then coming to our NH experience, these are the statistics. TRUNCUS arteriosus.
Slide not moving.
Okay, sir.
Narayana experience.
Now, sir.
Yeah, I can see.
Yeah.
100 cases.
Yes. So this is from 2017 to 2024. This is only of 2 surgeons because they are being there for all these years. Now, rest of the 2 surgeons have been not calculated. So on an average, around 10 to 15 cases every year happening, and mostly everything combined 100 cases. In coming to the trends of how these cases happening is that most being operated around 6 months to 6 weeks, 6 weeks to 6 months of the age, with extremes of age that is some patients being operated around 2-3 years also. So coming to 2017 cases, all the 2017 cases, the preferred.
On the still same slide.
Yes, sir. Same slide.
Okay.
So all the 7 cases, only 2 are modified Barbara Marshall. Remaining 5, the conduit used are homografts. So homografts are being downsized to match the size. So slowly over the years, the choice of conduit being used has been changed. Around 2019, it's being changed to PTFE valued conduits. So now no one is.
Your slide is still stuck at that first slide. TRUNCUS arterios repair under 2 surgeons.
Yes, sir.
Is that what you're talking about? You didn't split these to different procedures?
I split. There is one more this thing, sir, but this slide has means I have not written particularly what MP. So conduit preference has been changed over the years in our institute, and Barbara Marshall technique is being rarely done around 5% of the cases in all these cases. Coming to so being PTFE conduit as RVT conduit, I have taken separately from 2019 to 2021 statistics. That is only the patients with PTFE valued conduit as RVT-PA conduit being used. So 2019 to 2021, total 38 cases with 71% infants, that is 1 to 12 months, and peak age is 1 to 6 months. So gender is almost equal, 50-50 percentage. And coming to clinical characteristics, type 1 is 51%, 52%. Type 2 is 26 and type 3 is 15.8%. Valve anatomy, tricuspid 71, bicuspid 80, and quadricuspid 11. Actually, a little different from the outside statistics. And then regurgitation severity, mild in 39, none in 21, and then severe in 7.9%. Surgical metrics, conduit size most commonly used is 14, the bigger one is 16, and in some cases there is a necessity that we have to use 12 also, almost, although it is not recommended to use a 12-sized conduit. And then truncal valve repair is being done in 4 cases, and truncal valve replacement is done in 2 cases, along with the root in one of the case. And then CPP time, median time is around 139 minutes, and cross-clamp time is 95 minutes of a median, around 1 plegia time. And then high risk groups are the aortic arch interruptions. That means in these 38 cases, there are 2 aortic arch interruption cases which had higher CPP time as usual it should have. And then most of the patients will go chest open. That means almost 45% will go chest open. That is 17 cases. And with delayed chest closure after 24 to 48 hours. And post-op timeline, that means ventilation median of 54 hours, around 3 days, and ICU stay median of 8 days. INO being used in most of the cases, being all these cases are having severe pulmonary hypertension, and for management is also people will use INO, even though there is no indication as of sometimes. And then PD is being used in 3 cases. Delayed chest closure, all the chest open patients will obviously bleed or have collected in the under the blood bag, which needs chest wash. That means 4 times more risk of re-exploration. mortality is around 2 cases, that means 5.3%. Explorations are 13.2. And then conduit replacement is after 2-year follow-up is 1 in 1 case, that is at 21 months. So survival is around 1 year 92%, 92.1%, and then 2-year freedom from reoperation is 89%. So these ongoing studies in inclusion to the including all these statistics is that freedom from reintervention post PTFE valued conduit as RV2PA conduit, and then outcomes of patients on ECMO with PTFE valued conduits, and freedom from reintervention post homograft implantation in RV2PA, and outcomes of RV2PA conduit change, and outcomes of reduced sternotomy as a whole in pediatric cases, including these truncus cases. That's all. So all these studies or thesis things are going on in our institute at present. Discussion. Thank you, sir.
Thank you, Mohan. I'm sorry I will not be able to do much comment or this thing on this because I have no experience of operating on truncus. Maybe Jairaj sir can enlighten us better.
Yes.
Over to you, sir.
Now, my main comment is about not exactly related to the article, but from the center the article is published. Royal Children's Hospital, Melbourne. That's where
Yes, sir.
I was trained for 6 months during my between 69 and 72. When I was learning cardiac surgery, 6 months I was posted in Royal Children's Hospital. That time it was not a great center and not great research. The Sydney Children's Hospital where Colin was trained was much better. Later on, after joining CMC, 1978, I went there for 6 months. By the time Royal Children's Hospital had improved very much. Then 1993, I was working in Muscat. They sent me to Royal Children's Hospital to learn switch operation. That time, the great Roger Mee was the head of the department. And Shunji Sano, the Sano Shan fellow, was a registrar from Japan. And there was a very good surgeon called Bill Braun, William, an Englishman who later on went to the Birmingham Children's Hospital in UK and became one of the best cardiac surgeons I've seen. If you ask me what the best cardiac surgeons I've seen, probably Dentally, Pacifico, and probably Bill Braun. The greatest thing is that the great Mark D. Level, we all admire him for the modified BT shunt, was working in the Great Ormond Street. At that stage, he said he had a lot of mortality in switch operation. He stopped switch operation, went to Bill Braun and learned new techniques, and came back, and he had the guts to publish that as an article in the JTCVS. How he learned and his research improved. That's apart from the story. And then the other person is, I think, Tom Carr, who was also there at the same time. I think he was today's boss. I don't know where.
Yeah, yes, yes.
Later on, he shifted to USA. So that apart, the most important thing in this is the greatest risk factors in surgery for truncus arteriosus. This is one, the truncal valve regurgitation. Number two, the association of interrupted aortic arch, usually the type B, which is about 10 to 20. And number three, the coronary anomalies. The coronary anomalies, the most dangerous ones are the single coronary artery, the next one, long intramural course. So these are the three main factors which cause mortality in TRUNCUS. The interrupted aortic arch.
Coronary
But somewhere in your follow-by, I was amused to see that the mortality of the survival of interrupted aortic arch with TRUNCUS repair is 83% at the end of some period, and straight TRUNCUS repair 74% survival. I didn't understand that also. It's usually the other way. And the mortality mentioned in books is about 3 to 20%. Whereas our results are very good according to this 5.3%. I think it is a great result. And then you didn't describe the detail because you have to know everything about the conduits used.
Yes.
For a long time, Contagra was important because it's available also 9 to 11. What is Contagra graft?
Bovine jugular venous graft, sir.
But with a valve. See,
yeah, it's a valve.
Most of the there is a needs a valve. When you describe the PTF also, you didn't mention the valve, because you have to construct.
It's a PTFE 0.1 mm membrane valve.
With a thin Gore-Tex membrane, you have to insist. The problem of all those cases of repair with non-valve conduit is that there will be free regurgitation. And it's like the rub procedure you do instead of a Rasterly procedure. Some of them, they try to make a monocus pericardial valve, but that's not good enough. And nowadays, many surgeons have started to have PTFE graft made on the table because you can make all sizes. The problem with a homograft, either homograft aortic valve or homograft pulmonary valve, it's very difficult to get all these sizes from children's cadaver, So on the shelf availability of but then on the shelf is available, the proceed or xenograft conduit with valve is available. I don't know whether we use that or not, but I think most surgeons have now moved on to PTFE
valve conduits.
With a on the table made. That's also now used for most of the Rasterly procedures.
Yes.
And when you use without a valve, one of the procedures is Barbaro Martial. What is a Barbaro? What exactly do you mean by a Barbaro Martial procedure?
Direct anastomosis of RV2P, sir, with intervening autologous tissue.
What exactly do you mean by
that? The lower end of the pulmonary arteriotomy site being attached to the upper end of the ventriculotomy site, if it is actually in proximity.
Then they use they use the lower end of the pulmonary arteriotomy. They make use of the left atrial appendage on the posterior wall. So the lower end of the pulmonary arteriotomy is suited to the upper end of the
lower LA appendage.
Because the inside pulmonary arteriotomy will not reach the upper end of the ventriculotomy. So posteriorly you use left atrial appendage onto the top end, you anastomose the incision in the pulmonary artery, and the lower end is anastomosed to the upper end of the ventriculotomy. Then you use a patch with a probably monochus pericardial valve. So
Yes.
then later on this
ஸ்பெஷல்
they,
தான் ஹார்ட்டுக்கு சர்ஜரி பண்ண ஹார்ட்
I
ஆபரேஷன்
didn't get it.
ஹார்ட்
Some disturbance.
Then anteriorly they use a pericardial patch, the preserve glutaraldehyde preserve. Same procedure is used for the REV procedure. Instead of Rastelli, REV procedure done exactly like that. When you need a RV conduit for correction of pathology of virus. The other thing is, I've read somewhere, sometimes they do the decomte procedure because there's a chance of compression of the pulmonary
Compression of the pulmonary artery. Lecomte is being used when they are reconstructing the interrupted aortic ulcer because the length when they mobilize
the picture, none of them do the decomte manual. So they don't
Yes,
do that.
this maneuver, one of the indication is that.
Because sometimes the aorta with such pressure may compress on the pulmonary artery and pulmonary artery. Flow may be less. So the other thing is that most of these kids in our hospital, you said usually 6 months, but not textbooks say these days it's better to operate as early as possible. That's because now the excellent fetal echocardiography is available and the diagnosis can be made in utero, and such
Yes.
patients are shifted to tertiary care. And as soon as they're born, within 3-4 days, they start having classical left ventricular failure with feeding difficulties, dyspnea, tachypnea, tachycardia, and failure to thrive. In this case, classical thing is to treat the failure with diuretics and sometimes digoxin. I don't know now. Most people don't use digoxin.
Yeah, now
And sometimes if the ductus is closing, especially in cases of interrupted aortic and most common type of interrupted aortic arch along with truncus is type B.
yes.
And also I found in your main diagram of the method, I saw the aortic cannulation rather low and the clamp. Actually,
It should be higher.
that the cannulation should be as high or
As high as possible. Yes.
or innominate artery, because if you go into deep hypothermia circulatory error, anti-grade perfusion can be given to the innominate artery. So that's important. High cannulation of the innominate artery directly or sometimes.
Or sometimes with a conduit is also with a vortex conduit.
What is the cannulation for an interrupted aortic arch? Interrupted aortic arch, there is a discontinuity because lower half of the body is perfused.
Cannulation will be the same, sir. Only thing while going on pump, we have to snare the branch piece, not the MPA. And then go on deep hypothermic circulatory arrest with selective cerebral perfusion if needed, and then repair the same and continue with the antigrade aortic cannula.
In my ancient knowledge, interrupted aortic arch is innominate cannulation plus cannulation of the pulmonary artery. Because when you cool the patient with a interrupted aortic arch, whole cardiac output you are giving to the your innominate cannulation or high ascending aortic cannulation is going only to the upper part of the body. The lower part of the body is all supplied by the ductor from the pulmonary artery to the ductor. In my ancient knowledge, We were all taught that for an interrupted aortic heart, we need cannulation of the pulmonary artery and the denominator artery. The other condition where you cannulate the pulmonary artery for sometimes venting the left heart. That I'm sure you must have seen many cases in Narayana Vidya. But the other indication for cannulation of the pulmonary artery is the interrupted aortic. It is my old knowledge, but I don't know what exactly is happening. Anyway, good presentation, good results in Narayana Vidya. So, the exams you should know what are the conduits used, what are the
Yes.
complications, because the contact graph was very popular, 9 to 11 millimeter, because most of them, you said you put only more than 12 millimeter cortex, but when you operate on a 3 or 4 day wound, right, the 12 millimeter is probably too big a graft. And so I think contact graft is not used much nowadays because one, the valve in the contact graft gets removed, becomes incompetent, and chance of endocarditis also. That most probably nowadays I came in Narayana Vidya, the PTF is available, reliable, available.
Readily available.
Is it true or not? Is it our practice to use mainly the PTF graft with a valve sutured on the table? Yes or no?
Yes.
You should know these things and you should know the complications. And you also said that this is a very rare complication. Textbooks say less than 1%. And textbooks say that in a complicated congenital heart disease, more than 4% of them are TRUNCUS
TRUNCUS.
arteriosus. It's one of the conditions where surgery is required urgently in the first week of birth, after birth. One that total anomalous pulmonary venous connection, inferior cavern type, where there is usually obstructed TAPVC. 3. Transported from the great artery. These are the main congenital cardiac conditions which require urgent surgery, probably in the first week itself. Pathologists usually don't need surgery in the first week. And the survival, you said 65% in the first month. Average somewhere not operated, 65% of them survive first year and first month, and about 85% of them die in the first year.
Yes.
Die in the first month, 85% of them. So this is the longevity of this. So they have to be operated. I think. Previously, we used to, to prolong the life of a graft, because they all need reoperation, to postpone the operation, but that's not a good thing. Because you said in 6 months, in such cases, the PVR increases and becomes inoperable. That's one of the indications of cardiac death nowadays.
Yes.
To assess the pulmonary valve, because most of the other parameters you can obtain by a good CT. MRI is also good. MRI has got a problem that in a neonate, in front of ventilation, and the MRI takes so long to acquire all the details, so probably contrast CT is the best thing.
Yes, sir. Mostly CT is being MRI no one uses unless otherwise there is a truncal valve regurgitation which is causing LV dysfunction or biventricular dysfunction. Then we have to differentiate between then only MRI being
Those
used.
main things you get acquired by a good echocardiographer. And these people have said, that's a very important thing, if the truncus regurgitation is moderate or severe, it's better to repair it. If it's mild, they said no need to repair because this mild regurgitation may last even for 25 years, you know. And they said
Yes.
the indication to a truncal valve repair is only when it's moderate or severe. And in that diagrams beautifully given how to repair one
Truncal valve.
subcommunicable the redundant part of the cuspid can be, that part of can be excised. Then sometimes it's shortened, pericardial patch enlargement. Then the making the quadricuspid to tricuspid by excising one of the, and then
Rudimentary work well.
reduction and annuloplasty. That also was given nicely in that diagram. But any other doubt or questions?
Just a matter of curiosity, do we have irradiated blood in our institute?
Yes, sir. Yes, sir. We have to notify them early.
You get that? Oh, okay.
Yes, yes, we get that. We use for all HBS AG positive patients and then this absent thymus patients.
Okay.
I think most of them give. What is the test you do for that? What is FISH test? FISH. If its patient is positive, like the Dye-George syndrome, 30% of them may have a truncus anomaly.
Yes,
Tell me
sir.
two things. What is FISH test? What
Fish,
exactly
fish is
is
fluorescence in situ hybridization.
very good? Fluorescence in situ hybrid. If FISH test is positive, they may have Dye-George or catch-22. What exactly mean by catch-22 or 22q11 deletion? Well, very often we remember
Chromosome
things
yeah.
with the first sentence, with the first letter. We have got Sister Lucy, you know, something like that for the branches of of the external carotid artery. What do you mean by catch-22? C in CAN or cardiovascular anomalies, A for abnormal phases, T thymic hypoplasia, C hypocalcemia, H the hypothalamic syndrome. That's why they call catch-22 syndrome. They got hypocalcemia, thalamic hypoplasia.
Hypocalcemia,
That's it.
hypoplasia thymic,
The second is cleft palate.
cleft palate. Yes, sir.
Cleft palate. The catch-22 or the
Catch 22.
these are some of the things in old examination. These are 22q11 disease.
22 kilo.
Peculiar phases, normal phases, or you always call a syndromic phase. Every congenital heart disease when you present, you say whether they've got a syndromic phases. That's why radiated blood is very important. Anything,
Yes.
anything else? 8:42. Stop.
Okay.